Good morning for those of you joining us. I am Eric Tortosa, SICO National Delegate from Panama, and as you can see, Chief of the Arthroscopy Unit and Continuing Medical Education from my hospital in Panama. It is a pleasure to have you all here with us today. So, now we're going to talk about breaches in patient safety and the current situation in malpractice, especially focused on the Americas. So, the way this talk is structured is that we are going to review some statistics in malpractice in North America and Latin America, which is there is not much, but discuss the relevance of risk factors for malpractice and ways to prevent them. So, if we take the time to look at the literature, we can see that malpractice and patient safety incidents are commonly reported throughout developed countries. There is an they are being increasingly reported throughout emerging nations, India, Brazil, and such. But still, they are grossly underreported throughout the developing countries, such as my own. So, when we look at American data, we see that orthopedic consultants and institutions tend to be the most attractive targets for medical malpractice suits. More than 50% are related to acute trauma and degenerative cases. The lower limb, being mostly the hip and knee, are the most contentious issues. In the upper limb, the hand, for which there are a couple of interesting points about hand issues that we'll talk later, and more than 50% are related to surgical events. This is very important. More than 50% are related to surgical events. With about 25%, and this is really a large number of complaints to come out from just ambulatory care without ever having laid a hand on a patient yet. So, okay. Most cases are solved in America by mutual agreement. That means that somebody has to pay someone. The highest indemnizations currently being awarded are for spine surgery cases, hip cases, and there is a disproportionate amount of awards being given to patients with hand complaints. It's way, way out of proportion to the harm demonstrated but perceived by the patient. So be mindful of this. When we look at the data from Latin America, there's, again, not much to go on, but we did find some interesting things coming out of certain countries, such as Mexico, where the National Medical Commission between the years 2002 and 2008, in a report including 51 cases, all concerning orthopedic complaints, used a 20-item evaluation instrument. And the results were that women were the most common plaintiffs, 59%, the most common age group between 45 and 64. Most of the complaints were directed against public institutions, 35 against private centers, and they were largely by vast majority second-level facilities. Not primary, not tertiary, but mid-level facilities. And surgical attention was involved in 76% of cases. There were documented irregularities in diagnosis and treatment in 45% of cases. There were irregularities in treatment in 33% of cases, with a 20% of cases being considered correctly managed. 31% cases, negligence proven, 61% of those, negligence proven. And now you're in a legal quagmire because the governing body of orthopedics there had said that you had simply not followed protocol and you are on your own. That is bad. So, the lumbar region was involved in 21% of cases. Damages were considered patrimonial in 55% of cases. Physical in 38%. Look at this. This is significant. They are claiming a patrimonial damage more than a physical damage. And this is another very important thing. The clinical file will save you or sink you. 71% of clinical files were considered as adhering to norm, that they were in order, that had all the necessary elements to evaluate and sustain your case. So, they concluded that correct medical behavior not only implied correct application of knowledge and skill, but also adherence to the duties imposed by the lex artis, the way you are administratively and procedurally bound to do so, adequate application of technical resources as well as compliance with existing laws. So it's not only about your knowledge and skill as a doctor, but the way you do things following established protocol. And this is an important word to take back home and think about it, because this is the way basically you operate in your country, given the circumstances particular to your own environment. But each country has the way we do things here is such and such. And believe me, you better pay some mind to this. So, from Argentina, Dr. Reinaldo Ludueña, orthopedic surgeon and consultant for the forensic medical system over there in 2004, published a very interesting series of 57 cases against all orthopedic surgeons. As Samer said, in some countries, you, as a physician, when a complaint is brought up to you, you will be tried penally, civil, and in commercial courts. For example, in my country, you will first be tried through a penal system. If it does not go according to the plaintiff's complaint, he has the option to bring you to civil court, but never commercial. But here, again, you will be tried at all levels if possible. So that makes life triply more complicated. Now, the lumbosacral spine, again, was the most common area of complaint, followed by the hip, the knee, the femur, and the ankle. The main cause for complaints were death in 25% of cases, infections, 21%, higher than expected postoperative pain, 20%, wrong side surgery, 4%, and other, and 30%. So there's another 30% of, that's a big chunk of the problem as well that is not specifically detailed. This is very important. 16% of legal actions were triggered by comments from other orthopedic surgeons. You have to be mindful of this because any wrong comment said or any well-thought comment said at the wrong time could open up a door to a disaster. Okay? And of course we know that there are countries or professions in which colleagues are not as correct with their other colleagues, so it's very common in certain societies for them to deliberately, mislead you. So, common elements that Dr. Dueño reported in these cases are, and this were, this keeps coming no matter where you go. These elements keep popping up all over the literature. Poor patient-physician relationship. Why? Because again, we're surgeons. We are 90% of the time not in the out clinic. We're somewhere in the hospital doing operations or working in the emergency rooms, and we don't take the necessary time to talk to our patients and their families. We are great technical surgeons, but we are very poor at communicating efficiently with patients, with relatives, and staff. Poor respect for informed consent forms. And this is not only a problem for the surgeon, but it reflects an institutional lack of understanding for this. As I said, your chief, your immediate chief, the chief of your department, the chief of your unit, the chief of surgery of your unit, and the medical director of your unit must be aware of this problem. And as I said, inappropriate comments by other colleagues. Now, risk management, and these are the next two very important slides in this presentation. We will go about this. The clinical history, communication, informed consent, technical flaws, infection, wrong side surgery, and DVT prevention are basically the biggest risk factors that we need to take into account. So communication, as I said in the earlier talk, you have to communicate. See, we here in Latin America are very used to giving orders and having those orders followed, and period. The doctor gave an order and that's it. Well, that's not the case anymore. It's changing. Not only we need to maintain good communication, not only with patients and relatives, but with other staff and colleagues. We need to talk to other people. As I said, we tend to be viewed as technically gifted, but very poor communicators. In the clinical history, it must provide a clear insight. And we always are hampered by poor handwriting, even poorer history taking. We just take shoulder, 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 ankle, ankle, ankle. We forgot about diabetes, high blood pressure, allergies, all the rest. Poor notes, as Samer's case in the beginning illustrated. Poor documentation of patient care instructions. We need to write down the care plan somewhere in the chart as well, not only give them short notes. And as again you brought up earlier, poor documentation of patient non-compliance. If he chooses not to obey, you must write it down somewhere. Now, informed consent, you already went after that. It must clearly record that the patient was properly counseled, must be tailored to the specific procedure to be considered, must describe clearly all frequent. You don't have to go to 1,001 complications, but you have to go with the first, the most common complications. And the patient must be given sufficient time to review. They cannot sign it on the way to the OR, especially with electives. They have ample time to think about it, bring back more questions, so don't rush it. You have time. Technical flaws. Well, most cases are due to hardware failure prior to fracture consolidation. This is in cases of trauma. Inadequate fixation is also a common issue when you have a problem, as again, before the fracture consolidated. Surgeon experience is an important factor in this issue. You used the right plate for the right fracture, but you just did not get it right and something went wrong. Now you're in trouble. Leg length discrepancies are a common complaint, especially for women. Especially for women, leg length discrepancy is an issue. You have to warn them about that. They will not be happy. They will get a second, third, fourth, fifth opinion until you concede that the leg length discrepancy is real, and then you are in a problem because they have to go through 5 other consultants to come back at you and say, hey, I have a limp and it's related to that. So you have to warn them beforehand. Infections can clearly be a devastating consequence and have important implications. Must be clearly documented in the consent form that they were warned about. In most cases, they are considered an element beyond the control of the surgeon, but you must prove that you and the hospital acted correctly and timely. While you may not be judged unfairly for having an infection, you will be treated harshly for having ignored a patient with an infected something out there on the ward, out there on the outpatient clinic, and not having diligently treated it. So this is, again, very important. You must prove that you and the hospital acted correctly and timely. Document all known patient risk factors, diabetes and such. What you did to correct them prior to surgery. I sent you to the dentist. You were sent for decontamination, for MRSA. Maintain high level. This is very, 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 very important. You can take all manner of measures in the pre and the post-op, but if you and your staff do not maintain a high level of discipline, and there is a very nice paper on the discipline score for OR behavior in prevention of surgical site infection. That's from the Academy, American Academy in the last 2 years. It's a great paper. Maintain high level of discipline in the OR. Hospital, you have to participate and must be mindful of the results of your hospital infection programs and know the rates of infections in your unit, not your hospital, in your unit, and preferably, of course, your hospital, at least the basic ones. Wrong site surgery. Well, this is bad. 41% of incidents related to wrong site surgery are related to orthopedic surgical procedures. There's a nice paper published a few years back stating that during a 35-year career, the average orthopedic surgeon has a 25% chance of having at least one incident such as this. Now, I myself, as an arthroscopist, am terrified of this. I'm really terrified of this because when you start working in lines with, several cases, at some point you are very likely to make these mistakes, and there is simply no defending this. There is no defense against this one. Basically, the only medicine for this is prevention, such as the Sign Your Site campaign to prevent wrong site surgery. The most common sites are the knee, 41%, and the foot and ankle, 24%. But again, there is really no defense on this one. You went in big time. Now, as pertains to prevention of deep vein thrombosis and pulmonary embolism, it is a well-known complication. Without prophylaxis, depending on what procedure you're done, but well, you were orthopedic surgeons. It is well described that our patients have a 40 to 60% rate of DVT incidence. The incidence of pulmonary embolism after DVT prophylaxis is estimated to be at around 1%, perhaps even less so with all the modern measures. However, despite advances in pharmacology, death rates have still remained fairly constant. So, remember, despite advances in pharmacology, the rates have not diminished significantly. It is a frequent cause of litigation, especially in cases of death. Again, especially in cases of death, but you must demonstrate informed consent. You're fried if that was not documented somewhere in the informed consent. It's over. You must also demonstrate that prophylactic measures were used, but also that they were timely applied and that your patients were properly vigilated, they were properly watched over after a given procedure, not only in the hospital, but when they were on the ambulatory setting. They called you a couple of days, I have a swollen leg, and well, we'll see you in 2 weeks when you get back. That is not acceptable. There has to be a shorter time solution to such an incident. This is preventable, as I said. Now, as respects adherence to DVT prevention guidelines, there was a big study done in 2008. It's called the ENDORSE study. It's a big multinational study involving 32 countries, 1,600 patients, and this was to watch out for the prevalence of use of DVT prevention measures in patients known to have medical factors and surgical risk factors for DVT. So they found that more than 50% of these patients at present in these hospitals had factors, both surgical and medical, but that there was a very low compliance to the administration of chemoprophylaxis. As implementing patient safety protocols. So again, you have to encourage the report of possible errors or adverse reactions. You must review existing systems and their flaws, and this is a process that you must involve everyone, from nursing, from medical, from management, from administrative. Discuss the problems with team members, and I don't mean medical, I mean everyone. You have to bring in everyone. You must maintain a good, effective communication with the rest of the staff. Improving communications, again, patient-physician, among physicians, and staff and physicians, as I said. Plan for an effective office visit. You have to establish rapport, you have to ask about the patient's concerns, recruit patient cooperation, give information. Again, you have to develop some empathy. You have to understand the patient's concern. You may not entirely sympathize with them, that's another thing, but you have to empathize with them. And you must end the encounter efficiently. As regards office communications, don't just walk by your secretary or your nurses without double-checking stuff. You have to talk to your staff. Develop a protocol for handling patient messages. You got a call from patient X. She said it's not urgent. She wanted to know about this or that. Well, you have to have a protocol to deliver message at the appropriate times. Post-it notes will work, but you have to develop some type of system to handle office messages. And of course, they must be prioritized. And preferably with someone who has certain understanding of medical issues, not just the average secretary. When writing medication orders or prescriptions, be legible, caution with drug names, try not to use abbreviations, try to include complete information, and we are now all over the world moving into the metric system. Handling information and lab results. You must completely, you have to have complete information, patient date of birth, you have to double check that. Make sure a physician familiar with the pathology reviews results. Don't just give it to the messenger in the ward to be delivered to the next physician. You will find disaster sooner rather than later doing that. Make a personal phone call with critical results. Whenever you are delivered something that is entirely abnormally wrong, you must consider reporting it to your superiors, to, again, your other colleagues, so that there is no mistake in this. It's very common to see a patient walking with a biopsy result saying tumor, cancer, 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 without no one having taken the trouble to call him first and say, you need to come and we need to go over your lab results. There is something abnormal, we need to talk to you about it, because that patient will run from 1, 2, 3, 4, 5 consultants and then come back to you 2 weeks later saying that you have not done properly in informing her timely of the results. Prior to any surgical procedure, as we have discussed throughout the lectures, informed consent, verify patient identification, sign your side. Remember, you are lost if you do the wrong side surgery. Discuss your plans with your team, make your time worth it. Time is expensive. Discuss your plans with your team members, and not only doctors, residents, juniors, fellows, OR staff, scrub nurse, Always have a plan B and have someone, preferably you, or someone you really trust, which again is not the ideal, verify that all instruments and implants are required. So you have to have a backup plan. This is another very important slide. This is the WHO surgical safety checklist developed in 2007 for the pause, before, during, and after surgery. It contains several key elements that have been shown in many studies throughout the world and through hospitals with different levels and in societies with poor countries, developed countries, emerging nations, to have been shown to have diminished the number of patient safety incidents and mistakes. As pertains discharge protocols, describe the procedures, not only one, you usually do more, so we don't need write hip replacement, but you didn't write anything else. Trochanteric osteotomy, etc. You didn't write that down, and that's important. Describe the procedures performed clearly. Describe neurovascular status pre and post-op and at the time of discharge. It must be clearly documented. Give clear written directions regarding wound care, weight bearing, medications, and their possible side effects. And you have to give the patient some way to contact you. Remember, you have to give the patient some way to contact you. So in conclusion, the rise in the number of malpractice suits is increasing throughout the developing world. Several potential preventable risk factors have been clearly identified. There is much as we physicians can do, but it's still a team effort. And I stress this part. Several potential preventable risk factors have been identified, and ways to prevent them have been clearly established since many years. Okay, we will proceed to the next talk. Thank you very much.